Hello, and a big welcome to one of our experts, Dr Mandy Leonhardt, who's a GP but has a special interest in the menopause and I presume gynae in general. Is that right, Mandy?
Yeah, so I'm not a gynecologist. I have more of an interest in hormones, the menstrual cycle, how it affects your physical, mental well-being, and the treatments for these conditions.
Great. So today what we're going to talk about is how, based mainly around hormonal migraines, the difference between those and general migraines. And Mandy has just shared a fact with me, which I'm sure we'll get to later, which I found astonishing. But Mandy, if you'd like to introduce yourself and just tell us your background in regards to the menopause, because I thought it's fascinating, what you have done to start launching the menopause in the UK.
Oh,
if that makes sense.
Yeah, so it's not just me. There are lots of people who have been raising awareness, to be honest, it's really a team effort. But I trained as a GP, and I did gynecology as part of my GP training, and I found that women are special creatures, and I think that they have different health needs, much more different than men, and we have a journey through our lifetime where we have different times where we are particularly vulnerable to puberty, our reproductive years, when we have periods that may bother us, that may affect us in the way we function, and then we're vulnerable again during pregnancy, or fertility may be a problem, and then the perimenopause, and then menopause. So there's so many stages that affect us, and I personally had some health problems that no one really believed me or wanted to take seriously, and fobbed me off. And then I thought, surely if a doctor can't access good quality advice, how do non-medical trained women get good advice? And then I basically started to look into it and trained with the British Menopause Society, and I got the certificate to become a specialist. And I also look at other hormones as well that have an influence. And we, together with a colleague, we also organized the first menopause cafe in the UK, not in the UK, sorry, in England. So it comes from Scotland. This is a social franchise which brings women together in an informal, confidential space. Complete strangers sit together. Also men, they are invited to, and they can talk about their menopausal experience. And my friend Kathy and myself, we organized 2 of these menopause cafes in Hampshire and Petersfield. And they were completely overbooked and with waiting. It just showed how much demand there is. And but I'm not really. I try to inform women on social media. I'm not as good as some other campaigners are, like Diane Dainspring, for example. She had the Make Menopause Matter campaign, which actually achieved in Parliament for menopause to be included in the school curriculum for girls and boys to be taught about menopause. So there are lots more of very, very active people out there who make a change. And I think in the last probably 3 to 4 years, it has really been a noticeable impact on the menopause in the workplace, awareness. And so women do not just put up with it anymore, and they should.
Yeah, and I think what's interesting, and obviously we're not just going to be concentrating on the menopause, we're going to be talking about, the impact of hormones on headaches, etc. But the fact that menopause has got a much higher, and when I said when you started the menopause, it sounds like you invented it. I absolutely didn't mean that one. But I think by raising the fact, there is far more awareness about menopause, women now, it's given women more of courage to actually speak out about it and say, particularly to their employers, I'm going through this, I can't do anything about it necessarily, this is my body naturally. And it's raised the area, not just for people in the menopause, but people generally, women and their cycle and how that can affect them at different points during the months, which obviously it does, and what we'll discuss. So moving on to looking specifically at sort of how the hormones change how we are during the months. And I think what we discussed is that starting off by just explaining what they are, how they're different from how a hormonal migraine is different from a standard migraine, and then looking at different ways that we can help to support and lessen the impact, I suppose, on them?
Yeah, that's true. So migraines are very common in women. So they are more likely, women are more likely to have a migraine compared to men. And so there are different triggers for each woman. We all know about the typical triggers: red wine, chocolate, certain types of cheese. And women know that, they avoid them, and then they can hopefully avoid the migraine from happening. So these are external triggers: stress, sleep deprivation, coming back from a long-haul flight, jet lag. All of these can trigger migraines in some women. Now, every woman will have different triggers. And the problem with a menstrual migraine is that these women, their trigger is the change in hormone level each month. So when we look at a normal menstrual cycle, and we are talking specifically about estradiol, we have two hormones that we make during the menstrual cycle, which is that's estradiol and progesterone. And that's what, at least we don't really, to be honest, we really don't yet know specifically what migraines are or what is involved. We have some idea, but it isn't quite clear. And the fascinating fact is also the brain normally cannot actually feel pain. But how can this organ create so much distress and pain, when it happens? And that's really fascinating. We believe that a migraine in general is caused by vasoconstriction, so by a spasmodic closure of blood vessels. So these blood vessels, they close up, the blood supply gets reduced, and that can trigger reduction in blood supply to the eye. So women get this severe throbbing pain over usually one eye, with often visual disturbances. Sometimes they go blind, or they lose their vision. They feel nauseated. They get an aura sometimes with stick-stuck patterns, and they sometimes are sick physically. They throw up.
Gosh.
As severe as that. So it's super debilitating. And what is very clear, it is not a headache. It is more than a headache. Any woman who had a migraine can tell you that you cannot function properly. You have to go to a dark room. If you're lucky enough and you take medication beforehand, you can prevent the full-blown attack. But if you do get the full-blown attack, you cannot function properly. You certainly can't work or look at a screen, and it can take several hours before this attack passes. And the difference between a normal migraine with other triggers and menstrual migraines is that the trigger is basically different. And while some migraines are triggered by foods or activities or stress, the menstrual migraines are triggered by hormones. But in the sense, what happens in the head, in the brain, is pretty much the same. And it doesn't mean that a woman who has a menstrual migraine can't get other migraines too, but she may be particularly vulnerable to changes in her hormone levels. But there's also something good in knowing that you have a menstrual migraine, because you can predict when it happens. And then we come later on to the treatment options. If you know when a migraine comes on, then you can do something about it. Other women who get random migraines, they can happen, overnight from 1 minute to the next. They cannot predict this, and they cannot do anything about it. So they have to take medication throughout the month and hope for the best that they don't come on. So in terms of hormones, when we talk about menstrual migraine, we're particularly talking about the drop in estrogen levels. So this is a very drawing of the menstrual cycle, and that only shows one hormone, and that is the estrogen. This is your start of your period when hormones are very, very low. Both of them, progesterone and estrogen, are low. There's not much there. You have your period, and then during the course of the month, in the first 2 weeks, your estradiol builds up towards ovulation. Ovulation is that ripening and maturing of an egg in your ovaries that pops out to eventually make a baby. Anyway, that is ovulation. Estradiol goes up and up and up. Ovulation happens, the egg pops out, and you can see how once that happened, it very drops sharply. And then this is the luteal phase. This is the follicular phase, and then this is the luteal phase. And in some women, that drop can trigger a migraine. In some women, in the peri-menopause in particular, what happens is you do have the peak and then terrible fluctuations in the second half. And it's not the estradiol itself, it's the change in the level, the sudden drop that women can trigger the migraine.
When you get these, is it something that happens, you know, do young people, I mean, never having them myself, you know, if you don't have things yourself, you're not aware of what happens. But does it happen from, you know, as soon as, you know, young girls start their periods, or can it start at any time?
Both. So I know girls who, as soon as they get a period or have regular cycles, from puberty, they have monthly migraine attacks. And if they track their cycle, they can tie it very closely to their period. And it's usually the week before your period is due. So yes, it can start from puberty, but I also know women who have the occasional migraine throughout their life, and between 20 and 40, they had the odd migraine, but nothing debilitating, and they could really manage that quite well, and it wasn't a bother. And then the peri-menopause starts, and that's when they get migraines every couple of weeks, or they get severe migraines towards the time of their period in the week before. Particularly debilitating. I have also met women who never had a migraine in their life and only got migraines in the peri-menopause. So that is a particularly vulnerable time. And again, if we look at fluctuations during a lifetime, so these are your estradiol levels throughout your lifetime. At birth, it goes up, and you can see how these changes during puberty can also have an impact on your brain, right? This is your estradiol going up, and between 20 and 40, you have fairly regular levels each month. And this is the peri-menopause. You can see those severe fluctuations there of estradiol, and they are so unpredictable. They can really trigger these migraines in your brain, much more so than in a woman between 20 and 40, but they do get it still. The woman in her 20s may get it very much like clockwork. Every month she might get a migraine, whereas the perimenopausal woman may get them all over the place. So this is a particularly vulnerable time for migraines.
And how long did you say they last? Roughly, was it 5 days? Did you say, or did I make
the vulnerable time? Yes. So it depends how long your cycle is. If you keep a diary, and this is a really important tool, this is the crucial bit about diagnosing menstrual migraine, to keep a symptom diary. It is a requirement to actually say that you have menstrual migraines. Keep a diary, track your cycle. If you notice that you get your migraine 2 days before your period starts, that's when you can take action. And yes, so there is a vulnerable time frame. Some women get their migraines right after ovulation, so that would be day 15, 16 of their cycle. Other women get their migraines precisely 2 days before their period starts. Due to prostaglandin release. That's another chemical in the body that may trigger migraine. So that's why it is so important for each individual woman to track her cycle, to find out when is that time when I tend to get my migraine. And we can only tell that in hindsight, you know, looking back, we can only say, oh yeah, that month my period came on day 27, and my migraine wasn't day 25. And if you do that over 2 months and you find that pattern, you can then take preventative action a few days before you expect the migraine to happen. And that's the crucial bit. And the most important thing about this is that if you know when your period comes on, and you know when your migraine may come on, you can take preventative medication in the days before that is supposed to happen, and you do not have to take medication throughout the month. So some women who get very erratic migraines, you know, 3 times a month with no pattern, they have to take medication throughout the month, every single day, because they can't predict when their migraine comes on. And these treatments have side effects, whereas the woman with a menstrual migraine, she can prevent having to take something every day, right? And that's a good thing.
And I think that leads on neatly to, before we go on to looking at the sort of self-help things and all the things you can do to manage it better, is to go on to the fact that I said that you told me earlier, as to actually how bad these migraines are. And I think it's really important, if you explain how bad they are, that allows us to explain to people, you know, for example, in the workplace in particular, is to what it really means to have one of these migraines.
Yeah, so I did actually, when I looked at the statistics, I saw that it was mentioned that migraines are listed as number 6 the sixth disability in the list of disabilities. So if you're registered disabled, migraine is number 6 in the list. So after someone who's in a wheelchair or had a stroke or other disabilities that prevent you from doing a full-time job or functioning properly, or having lots of sick days. So number 6 in the statistics, that is, and obviously the majority of those will be women.
And I just think that's so important. If one can, first of all, identify the type it is. So as you said, then perhaps you don't need to take so much medication. And then the next thing is to be able to know facts like that, so you can explain, especially to your employer, this is how severe it is. It's not just another headache. You know, I'm incapable of working at this time, and then maybe work around with your employer as to, well, okay, I can't work these set hours, but I can do other hours. So you manage it. And obviously that will probably take off a lot of stress, which hopefully would improve the headache potentially as well. But anyway, yeah, it'd be really interesting to know how you feel that so tracking is one of the first things.
Yeah, tracking is a diagnostic tool and also part of the treatment plan. It is very important that you get, because some women think they have menstrual migraine and they're not, and they actually would not benefit necessarily from specific treatments. So unless you can predict when your migraines come on in relation to your periods, these treatments that go through in a minute will make no sense, because some of these tablets, some of the treatments you're supposed to 2 days before your period starts. And it makes no sense if you don't know when your period starts. So in women who have an irregular cycle, it's a bit tricky. They may need to take something for 2 weeks and they may have to guess it. And there might be times when they take a certain medication a bit longer. In some months, they may take it a bit less often. So it is sometimes a little bit of a guesswork, but it is still important, even if you have irregular cycles, to track your cycle. And if every single migraine happens 2 or 3 days before your period, then that is a menstrual migraine. That is very likely. If you never get a migraine in the first 3 weeks before your period, after your period, in the sort of in the follicular phase, then you're migraine free that time. Then you have a hormonal migraine, which is linked to your menstrual cycle. The good news is, on the other hand, when you're menopausal, your menstrual migraines will stop. So you should not really get any more migraines. Once you're menopausal, you have no more hormonal fluctuations, and that's the cure for migraines.
So that's one perk. That is one.
Yes.
Perk.
Yes.
That's very true perks.
Yeah, that's true. So yeah, keeping a symptom diary is really, really important. And in the perimenopause, sometimes women bleed every 2 weeks, or they bleed really randomly, and their migraines are all over the place. In those women, treatment looks a little bit different, and they may actually use, for example, HRT throughout the month, and that will prevent your migraine throughout the month. But in the younger woman who very much only has 2 days a month where she's vulnerable or has the migraine, she doesn't need to take treatment throughout the month and have the side effects. She can just take it before the period. And that is the advantage of knowing to do when it's connected.
So one of the things that we also spoke about earlier was about potentially using supplements.
So supplements, there are some supplements that can be very useful. In particular, so some supplements do have side effects as well. So don't think of supplements as always safe. That isn't quite true. Some supplements cause problems as well. But when it comes to migraines, one of the biggest supplements that I really like is magnesium. Magnesium is very safe. It's a very important mineral that is involved in more than 300 enzyme activities in the body. It is a muscle relaxant. It helps with depression. It speeds up metabolism. It is also a mast cell stabilizer. So the mast cells are the cells that contain histamine. And there are some theories and some evidence in the literature that some women are histamine sensitive. So that might be a trigger for their migraines. And estrogen stabilizes histamine cells, mast cells. However, when estrogen fluctuates and drops, that destabilization opens up the mast cells and releases histamine. So some women actually are helped by taking an over-the-counter antihistamine in the second part of the month, which is astonishing. It's a very safe, it's not a supplement, it's a medicine, of course, but this is very safe, has very few side effects, and it either works or doesn't. But if that's the problem, if the histamine release as a result of the fluctuating estrogen levels triggers your migraine, then taking an over-the-counter antihistamine can actually work a miracle. And it's something that a lot of women don't think about. They think, how can his antihistamine work for migraines? What's the connection? Well, that the connection is the estrogen and histamine connection. So that is one of the things that it's not a supplement, but a medicine. Magnesium, 600 milligram, and just be mindful that 600 milligram daily for several months, you have to take it several months. So this is the difference between a medicine and a supplement. Supplements do not work immediately. You have to take them for a longer time frame before you see the results. So, but you can take the magnesium alongside any medication. It tends to not interfere with many things. So it's very safe. And types of magnesium, certain types of magnesium are better than others. So you want to look at magnesium glycinate, malate, or L-threonate. There's one type of magnesium you want to avoid, which is called magnesium oxide or hydroxide, which is a very cheap magnesium and very widely available. However, it is very laxative. It can actually cause you loose bowels. And a lot of women also, they get period diarrhea from the prostaglandin release. So you really do not want to use that magnesium hydroxide if you have IBS, for example.
So you mentioned about, because we're looking to launch a support program about vitamins and minerals, and it is a complete minefield, and I think you've just opened it up. You know, I would just go and have a look. Oh, it says magnesium, I'll have that. So you're saying that you have to be careful, and the most common one is the one that's not great.
Yes. No, I'm not saying magnesium on the whole isn't expensive, but the ones that are on the shelf, like let's say in the supermarket or the supermarket's own brands, they tend to be magnesiums that are very poorly absorbed and cause gastric side effects. So you need to specifically look out for choosing a type of magnesium that isn't that. And the other problem is that magnesium, let's say you take a multivitamin and you look at the label and there's magnesium in there and you think, yeah, I'm taking magnesium already, I don't need an extra magnesium. Well, magnesium is a large molecule, and 600 milligram is a lot of magnesium, which means you have to probably take 2 or 3, if not 4 capsules every day, because it's bulky, it takes up a lot of space. You will never find 600 milligram in one capsule, and you'll never find it combined at that high dose in a multivitamin. So I don't like multivitamins because often you have too much of something you don't need, like often vitamin A is way overdosed, and often you have too little of what you're really after. So do take a specific magnesium supplement. Don't think that what's in your multivitamin is doing the job. It won't. 600 milligram, 400 to 600 milligram is an awful lot of tablets you have to take. Be mindful of that, but it may be worth it. And the other thing that is really valuable probably is making sure your vitamin D levels are not low, which is very common in the UK. There's some association with migraines, and vitamin D is very important for so many other things, as we all know. And then B2, that's another supplement, vitamin B2. Now, the recommended dose and the clinical trials is 400 milligrams. The daily recommended requirement is 1.1 milligram. So you have to take almost 400 times more than the daily recommended requirement dose. So you cannot get that from a multivitamin. You have to buy a targeted B2, a vitamin B2 in an individual capsule. So that is important. And that if you take supplements, you have to take them at the required dose, which is often much, much higher than the daily requirement. And you also have to look at the other ingredients that are in there. So they have to be safe, they have to be from a reputable company, they have to be standardized, and it's a bit of a minefield with supplements, but it can be hugely helpful.
Yeah, I mean, that's why we're going to create this program, because there is so much out there. And as I said before, I probably talk about it every week. You go into a shop, which one do you choose? Do you just go for the one that's got the prettiest label? Because it's so hard to know. And I think we're very keen, and I think it's very much, if you think you're fine, a multivitamin is great, but actually, is it really doing anything? And really look at what you need. And I think the other thing is you need to look at your health at different times during the year, how things change, and whether you're lacking. Well, vitamin D obviously is a prime example in the winter. So yes, I think it's really important to do your research, to understand what it is you feel your body is deficient in, and then look what I need, and then specifically the dosage that's required.
Yeah. And with regards to vitamin B, which is very, very helpful and also recommended for migraine prevention, I looked at how much how you could get this amount from food, and literally you can't. Oh, can I not recommend eating a certain amount of, beef or animal product? What else can they do to get this amount of vitamin B in through nutrition? And you can't. And that is quite an eye-opener, because that amount of vitamin B that has been shown to be efficient or effective in clinical trials, it's impossible to get from food. And that's where the difference is. Healthy eating is very important, but when we use supplements as medicine, it's a completely different thing.
I think it is. It's absolutely understanding what you need and what you don't, and it's when you're deficient, that's when food is not necessarily. And I think also the composition of our food over the last 20 years, I think they have proved, has changed so much. So what might have been in a lettuce, for example, is not in a lettuce anymore because of the way in which it's farmed, or the nutrients they put. It's amazing. It is amazing how things change.
And also, some people may not absorb vitamins and minerals very well through the gut, so they may eat a very healthy diet, but they may have malabsorption. They may have certain conditions that stops them from actually absorbing the amount they need to be healthy. And in those cases, I have to say, it is perfectly acceptable to supplement certain vitamins. And if you are vegan because you're conscious, that this is what your lifestyle is, it is perfectly fine. And most vegan people have no problems with that. They know they need vitamin B, and they take a vitamin B supplement, B12 or something. So it all depends how restricted your diet is or what your other health needs are. And then I personally don't have a problem with supplements, as long as they're meaningful and as long as the dose is correct and actually enough to make a difference, right?
Yeah. And it's a reputable company or brand that you're buying from, and a reputable, but not just the brand, make sure it's the website you're buying from is reputable. I think really
that's really important. So there is a company, not a company, there is a herbal supplement that I looked into, which was recommended some years ago for migraines, and it's called I don't really recommend it at all. It's Butterbur, so that herb Butterbur. The Americans are really keen on Butterbur, and there was a very good product that a company made to very high standards, and they brought it out as a pill for migraines, and it worked really well in clinical trials. Then the company changed their manufacturing procedures, and the way they extracted the herb included a chemical that could be liver toxic. And when they tested these new pills after they changed the manufacturing process, they found that there's so many chemicals in there that could potentially be toxic to your liver long term. And then European countries started to ban this coming from America. So Germany was the country that said, unfortunately, it is no longer approved, and unless you change your manufacturing processes, we cannot allow you to sell this here in this territory. And so this is the problem. And whilst clinical trials have shown that this specific herb extract was super helpful, the actual end product that you may end up taking could be harming your liver. And as long as we can't be sure that the safety requirements are there, I currently don't recommend Butterbur for my patients, because I can't recommend them a safe product, because I can't be sure that extraction process was. So that's why we have to be very careful with herbs as well. They can do sometimes damage.
Before we go on to, so we've spoken about supplements, which was really interesting. And before we go on to the medical treatment side, is there anything that we can do ourselves in the form of lifestyle exercise, for example?
Yeah, so exercise is obviously helpful throughout the month, and it's so important for mental health, physical health, for osteoporosis prevention. And yeah, so exercise is always good in a sense that it tends to be more beneficial than harmful for most people. However, I would say that the form of exercise you should be doing during the luteal phase, so that is the week leading up, the couple of weeks leading up to your period, if you find that the type of exercise you do creates stress for you, so if you push yourself hard, if you think, oh, I need to go and do that 10-mile run, and you feel really exhausted, and then you can't sleep because you're feeling a bit agitated, so maybe do that type of exercise, the endurance, the cardiovascular exercise, where you really push yourself to hit, do that in the first couple of weeks of the cycle, and then move on to something less stressful, because exercise can be a form of stress. It's physical stress for your body. It's good stress, but it releases cortisol. It can trigger problems. So maybe move on from the kind of this type of exercise to something more calming, like yoga, strengthening, Pilates, where you still get the benefits of the movement, but it's a different type of movements and less stressful. And also maybe some meditation after a yoga session will be helpful to calm the mind, to reduce the stress levels. So yeah, sure, you can vary that throughout the month. You don't have to do the same thing every week. You can adapt your exercise regime according to your menstrual cycle, and that can make sense.
But once again, it all goes down to listening to our bodies, isn't it?
Yeah.
Rather than just forging ahead saying, well, I ran 2 miles or whatever it might have been last week and I've got to do it this week. It's like, well, no, your body isn't receptive to that. That's more harm than good. So yeah.
Correct. And don't feel guilty if you didn't do that run that you were set out to do this week. Don't worry. If you have a week where you feel really bad, it is perfectly acceptable to just do some gentle stretching that day, you know, because I actually have women who over-exercise, and I tell them, look, you need to plan some recovery sessions in between your exercise sessions. Your body has no time to heal if you push it every single day. A lot of athletes know that their performance increase when they exercise less. This sounds strange, but it's true. They
absolutely.
One day and then they rest. They have rest days.
Yeah, you have to let your body recover. Yeah. So moving on then. So if any, by the way, I'm so bad, I always forget to ask, if anybody's got any questions as we're going along, and I know we've got a few in the box already, but if you could just please put your questions down and we'll come to them in a minute, that would be great. But yeah, so moving on then to, if you found that, you know, you're taking your supplements, you're aware of what's going on, but you still can't control I suppose the disabilitating factor that you have, there is medication that one could take, and I presume this is the point you go really to your GP and say, look, I need help.
Exactly. So obviously the one thing I haven't mentioned is try to avoid stimulants like caffeine, alcohol, nicotine, anything that stimulates you or makes you agitated, creating during that week before your period is due. That can be hugely helpful. And also make sure that you have a good sleep routine, good sleep hygiene, go to bed at the same time, make sure you have enough sleep during the night for your brain to recover. Sleep deprivation is a common form of migraine trigger as well. So if you sleep deprived and have a drink and you drink lots of coffee, you're more likely to get a menstrual migraine as well. So if you cut all those out and you still haven't found that works, or there's still no improvement, yes, you should go and see your GP, because you shouldn't put up with this. There are very good treatments out there. So starting with the very simple treatments, non-steroidal anti-inflammatories. These are the 2 examples are mefenamic acid or naproxen. These are a bit like ibuprofen in the same group of drugs, and they can be taken 2 or 3 days before you know your period is due, or before you think that migraine is going to happen. Now you have to take them 3 to 4 times a day, the mefenamic acid or the naproxen twice a day. They're only available on prescription. The other positive side effect they may have is that they make your period less painful and lighter potentially. So if you have that problem of heavy periods, painful periods, and that migraine, they may be a really good option for you. They have very few side effects if you only take them for this short time of the month. They are not sedatives, so you're not feeling drowsy. You can still drive, you can still do your work. And I find them a really useful solution, particularly for younger girls as well. But that is provided that you know when your period is due. Yeah, you need to time that again. So that there are different. So this is a good approach to start with. And that the triptans. Now, most women with a migraine know triptans. This is a group of drug that is normally taken as soon as you have the first symptom of a migraine. So you feel that the headaches coming on. You feel, oh my God, I feel the nausea coming on. And that's when you take your triptan, either as a nose spray or as a little tablet that you put under your gum that dissolves. And that the purpose of that is to prevent the full-blown attack. It may not prevent the whole migraine, but it may make the whole duration shorter, and it may the whole migraine lighter. But in the way we use triptans in the menstrual migraine is different, because you start taking these tablets even though you have no symptoms. You start taking something like triptan as a tablet twice a day, 2 or 3 days before your migraine is expected to happen. So instead of taking them on the day, in the moment when you think it's starting, you take them earlier, and that way we use them as a preventative drug rather than as a painkiller. And that is different, because that wouldn't work in any other migraine, and that's why it is so different. So it's important to track your cycle. And a lot of GPs don't know that this is unlicensed, in the sense that the actual drug is not licensed to be used for that purpose, but it's perfectly acceptable, and it is recommended for these drugs to be used that way. They're very safe. They don't have many side effects, and can actually prevent any migraines that may happen. So instead of waiting until it's already there, you start it 2 days earlier, and you won't get it at all, which is quite useful. Wow. So you've got the non-steroidal anti-inflammatories, you've got triptans, and then you've got antihistamines you can take that I already mentioned, and then you've got hormonal therapy as well. And that is not for every woman. I acknowledge that some women, for example, those with a history of breast cancer or any hormone receptor positive cancers, not every woman may be able to take that. But there's a whole range of options with hormone treatment. And particularly in the perimenopause, when we use this treatment, we can also at the same time treat menopausal symptoms like hot flushes, lack of sleep. And so there's lots of potential there when we're using hormonal treatment. One thing that a lot of women with migraines are told is that they can't take hormones. That's nonsense. If you have a migraine with aura, and an aura means you get visual disturbances, you get flashlights, you get this sense of foreboding before the migraine comes on. So you get that warning sign. That's what we call an aura. Women with an aura should not be taking oral estrogen. That is true. They should not go on the combined oral contraceptive pill. So, but that's the only exception. That doesn't mean she can't take any other hormones, right? And often they're wrongly told, you have a migraine, you can't go on HRT, you can't take hormones at all. It's not true. She could take the progesterone pill, which would be taken every day of the month, which may stop that cyclical pattern. She could have the depot progesterone injection, which gives you contraception and stops you from cycling. That is particularly helpful probably in the younger girls who need a secure form of contraception and who probably are not very good at taking a pill every day. So, but again, it's not for every woman, but for some women, it's really useful having the 3-monthly injection to stop you from having these fluctuations. Then we have the Mirena coil, which can be useful again for those women who have heavy periods or want to treat that part as well, and also want to have a secure form of contraception. And the nice thing about the Mirena coil is you can then add a bit of estrogen as well to stabilize estrogen levels throughout the month. In particular, the perimenopause, it's quite useful. And then we have particularly targeted transdermal estrogen patches that women can apply. I'll show you some patches. So these are examples of estrogen patches, different brands, different sizes. This one sadly is my favorite, but it's very commonly out of stock. It's called Estradot, and it's a shame because we do not have enough supply, and it's nice and elegant and small. We have got other patches which are now readily available. So if you've switched to something else and you liked your patches, Everol is back in stock. So every size and strength of Everol should be back in stock. So if you're still not back on your patches, you can go to your GP and ask for to be put back on patches. The nice thing about patches is that you apply them to the skin below the waist, the lower back, the buttocks, the thigh area, or some women put them on the lower tummy. I don't like that area, but I prefer the lower back and the thigh because the absorption is better. But you apply that patch and you change it over twice a week, so on the same days. And it releases estrogen very nicely, very consistently, and it takes care of those fluctuations. And in women with menstrual migraines, they only have to apply those patches for a week, let's say, for a week before the period, or maybe 5 days before each period is due, and then another 5 days after your period, and then you take them off. So you don't have to use them throughout the month. And they stabilize estrogen fluctuations. They come in different strengths, so you can work your way up and see how it works for you. It might be a bit trial and error, and then you may take a few months what works for you, but they're very helpful, and they're quite safe. And alongside, you can take micronized progesterone. But in the perimenopause, my experience is that often just taking micronized progesterone throughout the month is really helpful with menstrual migraines, and that's specific to the perimenopause. So Utrogestan, micronized progesterone, this is what it looks like, is available on the NHS. It's very cheap. It's the first hormone that diminishes before you become menopausal. It's not estradiol. Estradiol fluctuates like crazy, and while it fluctuates, you don't actually make progesterone because you're not ovulating. So micronized progesterone, I had one woman who had the most horrendous migraines several times a month. She had periods every 2 weeks. She was 49 years old. She was all over the place. She had to give up her job, and once she started micronized progesterone, she actually stopped having any migraines. It was like a miracle.
Wow.
It was, and that's often forgotten about. And now this is not in any guidelines. This is just based on my experience. And there are other doctors more kind of who understand hormones as well, who would recommend this. But just be mindful that your GP may not know about this. They may say, oh, what would you do? But it is really clearly there's a professor, Professor Jenny Lynn Pryor in Australia, who's done a lot of research on this, how micronized progesterone in the perimenopause can alleviate migraines, for example. And it hasn't quite made its way through into mainstream medicine and guidelines yet. It's very safe though, and it's something that most women who are not progesterone sensitive would benefit from.
Okay.
Hormonal treatments there are lots of different treatments, depending also on how old you are, and also depending on, do you need a secure form of contraception? And that's the deciding factor as well, because then you can choose either the mini pill or something like that, or you can go down the HRT route as well.
Right. So, well, I will add, I know that you're not doing any form of sales plug with.
Oh no, I'm not affiliated with that at all. It's only, and also the problem is there are no competitors. This is the only thing that we have in the UK. It's cheap.
But I think it's important, isn't it, is to understand there are things, and you can't necessarily expect your GP to know all these things, because they are a general practitioner. Yeah. But the fact is, knowing there's stuff out there which allows people to, and I think if you do have really bad migraines, you'll do anything, won't you, to try to find something, even if it doesn't take it away, but it improves it, is what people are looking for, is how to manage their lifestyle. Can we then quickly go on, because I'm just very much aware of time. We've got a few questions. If we can whiz through some of them rather. I seem to get a lot of headaches from screens, glasses, hereditary, etc. But I also think I get hormonal headaches. How can I differentiate a hormone migraine from other headaches? And what does a hormone headache feel like? So I think, you've made it very clear there are different types, but what is the big difference between the two? Is it
a headache? A migraine is not a headache. One who had a migraine will tell you that. The most common reason people might get headaches when looking at the screen is tension headaches. So this is because your neck, you have your neck, slightly bent forward, all there in the same position, and then the muscles in your neck shorten, and they pull on the scalp, and you have this constant pressure sensation in your head. That is not a migraine. A migraine is a debilitating, extremely severe pain, usually over one eye, and it's pulsating. It will you stop from functioning. Whereas a normal headache, or even if it's bad, will not stop you from having a conversation, or maybe, you might not be able to read a book, but you would be able to maybe listen to some music. And women who have a migraine will not have any of it. They will go into a dark room, switch the light off, draw the curtains, and they will just lie in bed and hope for this to get over. So that's the difference. And also they go. A migraine disappears. So a migraine comes, it's really severe, and then it goes away. It doesn't linger, doesn't stay on. There are some women who have very severe migraines that last for a long time, but once they're gone, they're gone. Whereas a tension type headache, which is related to the muscles or kind of musculoskeletal problems, can be there all the time in the background. But in general, the women, I don't have headache, migraines, but from what women told me, a menstrual migraine feels the same as any other migraine. There's no difference.
Right.
This is what it feels like. A hormonal migraine will not feel different from another migraine. It's just the trigger that is different, but the actual experience is the same.
Right, okay. How would you know if you need antihistamine or magnesium?
Both. I mean, so how do you know? Magnesium, we don't check magnesium levels in the blood. You can do that, but actually magnesium is very much inside the cells, so it's often not useful to do a blood test. We are all supposed to be deficient in magnesium, so you really wouldn't do anything wrong taking magnesium. How do you know you need antihistamines? It's trial and error. If you feel that if you're histamine sensitive, then there's certain foods that can release histamine, and including red wine, including fermented food, including certain foods that you think are probably healthy, but they can trigger a migraine because they release histamine. I would say that it's trial and error. If antihistamines are very safe, they have very few side effects, they're available to be bought over the counter. If you feel that it might be, if you tried everything else and nothing works, and just take an antihistamine every day from like 3 days before your migraine is due, once a day, and see how that works. And in my experience, it either works or it doesn't. If it works, you're very likely to be histamine sensitive. And then you need to look at maybe diet and also exclude histamine triggering foods in your diet during that week or in general. Yes, it's trial and error. I'm afraid there are no specific tests you can do. But again, antihistamines are really available and very safe, so it's worth trying.
Good. Do hemoplegic, I don't know how you say that word. It's a type of migraine.
Hemiplegic. Oh, yeah. Hemiplegic. Yeah, where you get paralysis in the face.
So do those migraines come into the I can't read, I can't talk, can't do anything, into Peri-Menopause bracket as my 45-year-old daughter suffers from these?
Well, you can get any type of migraine at any time in your life in theory, so this is just a specific type of migraine, and the symptoms that this woman gets are hemiparesis, so where you get numbness in the face, you get it affects the nerves in your face, and you feel numbness and lost a sense of sensation. It's still a migraine, and they're not particularly differently treated than any other migraine, where women just get visual disturbances or throbbing or any of these symptoms. So they're still the same type of migraine, and you would still try the same treatments.
Right, thank you. I've had menstrual migraines for almost a year. I'm 30 years old, and I have been trying I'm useless. Yeah, to help. The GP also suggests moving from the 21-day pill to the everyday mini pill.
Yeah.
To help with the hormone fluctuation. Is it a good idea for the rest of my premenopausal years? As we say, should she carry on with it?
Oh, okay. So if she's currently on the combined pill, and she obviously doesn't have an oral, otherwise she couldn't take the combined pill. The newest, or it's not that new anymore, but the recommendation now is to take the combined oral contraceptive pill, which contains both estrogen and progesterone, back to back. So you do not have a pill-free interval. The way you normally take the combined oral contraceptive pill, you take it for 21 days, have 7 days off, and then you start a new pack. Now, with migraine sufferers, they particularly are at risk in that pill-free interval. And you do not need to have a bleed every month. You can just take these pills back to back and have a bleed 3 times a year, a scheduled bleed, maybe not when you're on holiday, but just when it suits you. So yes, so if that pill currently does not cause her any problems and she feels well on it, the only difference that she can make, or the only change she can make, which may be really useful, is not having that break in between the packet and just take it back to back. The other option is obviously the progesterone only pill, and that's just one hormone that is just progesterone, is synthetic progesterone or progestin, and that is useful in women who are over 35 and overweight or obese and smoking. You cannot take the combined oral contraceptive pill if you're a smoker over 35. So in that sense, it's really, it depends on how she currently feels on that pill and what the side effects are. If she already has side effects and she gets breast tenderness or it affects her mood or libido, then it may be useful to move on to the progesterone only pill. The only problem with the progesterone only pill, I would say, is that you get more likely spotting and intermenstrual, or you get spotting and bleeding issues with that pill.
Okay. And we've got time for just one last one, so I'll randomly pick one. I'm sensitive to contraceptive products containing hormones, i.e. the coil and the implant. So would any of these hormone options be suitable for me?
The estrogen, so most women benefit from the estrogen. So using the patch, or let's say a gel, most women feel better when they use a bit of estrogen during, as I explained. However, it's the progesterone bit that often causes the problems. Now, long term, it's not advisable that you only use estrogen long term, because it can increase the lining of your womb, and it can longer term increase your risk of endometrial cancer. So these women who are progestin or progesterone sensitive are a little bit stuck. And if you really can't even use the Mirena coil, or you can't tolerate the micronized progesterone vaginally, which is a little capsule you can insert vaginally, if you cannot tolerate any of that, then that's a problem. And I have known women who had a hysterectomy for the purpose of being able to use estrogen only.
Gosh.
Yes, this is a tricky one. So progesterone sensitive women get very severe mood side effects on any type of progesterone or progestin, even whether it's the synthetic one or even the natural types, the body identical one. They feel perpetually PMS-like. They get bloating, they get low mood, they feel miserable. But it is a tricky balance between protecting the lining of your womb in conjunction with your estrogen and taking the risk. So some women will take cyclical estrogen and no progesterone at all, and they will have annual scans to measure the lining of your womb. But you may have to do that privately, because the NHS will, or your GP may say, well, if you take that risk and take this, and you know about the risk, then you need to pay for the problems that you may start. So privately, some doctors will give women estrogen only in a cyclical fashion, because you're not taking it throughout the month and only for 5 or 10 days a month, and you have a bleed and you shed your lining, provided that happens, you can then have annual scans to monitor the problems. But yes, your risk of endometrial cancer is higher, and it is really officially not advised to do that. And yes, these women have a particularly challenging time. So they need to look elsewhere. They need to look into supplements, maybe look into lifestyle. It's a multifactorial approach they need to have.
But I think that's the same with, every health area that we look at with our body. It's a fine sort of balance between everything, isn't it? Yeah. And you may find that what you thought was normal, or, you could just make a little change, and actually could make a big change to your whole cycle or your body, in fact. So anyway.
Don't despair. So just one word, if you feel you have got menstrual migraines, and just, it's so important that just think of it. If you're starting to become menopausal, if you're menopausal, that will be the end of it, hopefully, right? And so if you are in your late 40s and you're battling this and you can't take progesterone or nothing works, just remember, it will end eventually. There is some hope at the end. It's going to go on for the rest of your life, okay? So just be hopeful, be positive, and think of it as a phase. It will pass, and you will get better eventually.
But I think that's a very positive note, because I'm sure many women who do suffer from this in silence will just think, and one of the first things is, don't suffer in silence. See what you can do for yourself, and also make sure, everyone around you, as I mentioned before, in your work, get people to understand what you're going through, which makes life, I'm sure, much easier if people understand what's happening. So,
and the one thing, while you mentioned it with workplace, the one thing that's really important, for example, if you're a night shift worker, you are more at risk as well. So maybe if you feel that your night shifts and sleep deprivation and circadian rhythm disruption contributes to your migraines, speak to your employer, ask to not having to do night shifts. I know it's not easy, but it may be a possible solution that you don't do night shifts in that week.
It's just even understanding or knowing that could be one of the big problems. I'm sure have helped people. So on that note, thank you so much, Mandy, for coming to talk to us again. And I know that when we did a coffee morning together, that was really popular as well. So I'm sure this will have been really popular and hopefully help lots of people, not just now, but for when people, you know, go back and look at the recording. So a big thank you. Thank you so much.
You.
All right. Thank you.
And I have got a little summary on my Instagram account if you wanted to go through it, because I know it's complex when I just talk about the different drugs and the names. But if you wanted to have a look, I have sort of summarized it on my Instagram account. If you want,
okay, we'll take a look and we'll put the links onto our website as well. That's really helpful. Thanks very much, Mandy. Cheers then.
Bye.
Bye everyone.